Hello, everyone, and welcome. Thank you so much for being here today. I'm Jenny Gaines, and I'm the Director of Programs and Services at F.E.A.S.T. I'd like to extend a special thank you to the Emily Program for sponsoring today's webinar. And our topic today is a pretty important one, and one that I definitely had when I was a mom of a daughter with anorexia, and that is, when is a higher level of care needed? We're very fortunate to have Dr. Brad Smith here with us today to share his expertise with us on this topic. And before I hand it over to Brad, we have a couple of housekeeping guidelines. Please stay with your cameras off and your microphones muted during the presentation, and utilize the chat box to ask questions during the Q&A. We should have plenty of time at the end if you put your questions as the presentation is going on into the chat box, and we will get to those at the end. Hi, Brad.
Hi, Jenny. Thank you. Thank you for having me today. And thank you for everyone tuning in now and for anybody who's listening at a later time. So as Jenny mentioned, this is a discussion today about when to at least consider pursuing a higher level of care for individuals who need eating disorder treatment. And I hope to provide a practical approach for individuals and support systems. Um, some of my background is I've been working in the eating disorder field between 14 and 15 years. Um, I've been I'm a psychiatrist by training. I've also taken on a lot of administrative caps over the years to help organize and put programs into place or switch up programs in higher levels of care. So I'm coming to you from that sort of professional lens and background of when we might in the field determine that somebody could benefit from a higher level of care, and then help to apply that to individual decisions that you may face or your loved ones may face. And let's see, there we go. So we'll cover these general topic areas. We'll talk a little bit about the complexity of eating disorders. We'll just give some basic background around the levels of care and what that might mean to the professionals on the treatment side, as well as what they might mean for individuals seeking care. Included in that, I'll talk about some of the common criteria for how professionals try to determine what a good level of care would be, what level of support someone might need. And then we'll go through a set of indications that determine based on medical situations, psychiatric situations, or behavioral or readiness situations that can be involved in that decision also. And there's really no formula here. There's not an exact algorithm of what to do in which circumstance, because these illnesses are so complex and there's a lot of individual variation that has to be taken into consideration. But we do have some guidelines. Some of the guidelines are very complex themselves. And, I'll share some of those resources, but also try to share more kind of common red flags for when we might really be thinking that a higher level of care is around the corner. We'll cover a little bit of how to pursue the higher level of care, and then just some final perspectives for the support systems involved in loved ones trying to seek care. I like to start with this little saying because I think it's so appropriate, and it cuts through some of the stigma in eating disorders that having an eating disorder is certainly not a choice, but recovery is. And perhaps it's a series of choices along the way. The course can be long, it can be winding, and so there are a series of choices that an individual has to make along the way. But these are, make no mistake, these are illnesses. These are things that I have yet to run into someone who has chosen to have an eating disorder. And it's a little dated, but there has been stigma in the past about whether or not, because these disorders involve certain behaviors, is there a choice component in it, or is it really something that needs to be addressed like a medical illness? And certainly professionals in the field think that way. Any of you who have an eating disorder, or any of you who have a loved one with an eating disorder, would recognize that these are illnesses and it's not a choice. So let's spend a little time just talking about the complexity of eating disorders. Um, and I mentioned I've been in the eating disorder field for 14 to 15 years. I was in more general mental health psychiatry and public psychiatry, forensic psychiatry kind of settings for the first 10 years of my career. And when I moved over into doing more eating disorder work, um, what struck me in learning more about the history and studying more about the history of eating disorder treatment is I was struck by what I saw as the attempts to oversimplify these illnesses. You mentioned just a slide ago about whether it's a choice or these are behaviors. And I saw some similarities to how it took a long time, I think, for society, even for the medical profession, to come to a better understanding of substance use disorders as illnesses and, trying to pin things on a behavior or a choice. Um, and I also saw a history of trying to attribute these illnesses to maybe a single cause, some of which were really never helpful, especially to try to oversimplify it that much. Um, but I remember back in probably the mid 80s as, eating disorder treatment started to become more in the social sphere of awareness for people, um, that there's a lot of talk about it there being a cause related to family dynamics, parenting styles, and you know, that has been so far from the truth in terms of my experience in the eating disorder field. So it was sad and unfortunate and really damaging for these attempts to try to find a single cause for eating disorders. And it still has had periods of kind of going in other areas. Even before social media, there was a tendency to try to blame just general media depictions of people for, leading to body image dissatisfaction. And, and now we have social media, so all sorts of reasons to blame that. But like a lot of illnesses in general, and certainly a lot of, and almost all mental illnesses that I've come across, these are complex. And I think eating disorder illnesses are more complex than most other mental health issues that I've dealt with in my career. It's very humbling to work in this field because of the level of complexity. So, I hope and I hope that we continue to learn about all of the factors that may be involved here. But there is no single cause for an eating disorder to develop. Um, there are factors, multiple factors. Most often, we have some sort of understanding of this around how, genetics or just your own set of DNA may put someone at risk for certain illnesses. Could be an eating disorder, could be some other related mental health disorder. And then there may be circumstances from experiences that we have or experiences that um, put us into risk because of having been exposed to something, whether that's trauma, whether that's social media, whether that's, unhealthy body image. So all of these factors certainly can play a role, and often many of them play a role for any individual, but they're not easy, and they're not straightforward. So, as many of you know or have experienced, most eating disorders will affect both mental health and physical health. So, right off the bat, we're seeing something more complex than perhaps other mental health issues, more complex than other physical health issues because they affect both. And then wide disruption of functioning. We're likely to see people losing or damaging relationships with their family, friends. It's tough to maintain work. It's tough to maintain school functioning. Um, and really, I think of it as permeating people's lives. So it's very difficult when something touches that many areas of our life to really have a single approach for what works. Um, and it is very difficult to determine for each individual what that best course is going to be. And so I think of this as a lot of collaboration. That collaboration could be between an individual and their support system, and it could be collaboration of that individual with their professional providers, could be a collaboration of all of those, and maybe others involved. Um, and because of the complexity of all this, the treatment is complex. And I know when I was before I was in this field, I had a faculty supervisor way back in training who had done a lot of eating disorder work in treatment centers initially, and then he had worked in an outpatient practice on his own. And so people would refer individuals with eating disorders to him, and he said, "There's no worse place to be than to be a solo provider without colleagues to try to help someone with an eating disorder from a professional standpoint, um, because they're so complex, and you need this team of individuals that bring different expertise to the table to try to help." So we know that treatment can involve multiple different modes of treatment. It can involve certainly nutritional rehabilitation. So we also know that psychotherapy is one of the main treatment modalities to try to help with an eating disorder. And we may have a role for medications to be used in the course of treatment. Sometimes psychiatric medications, oftentimes some medical interventions to try to help with some of the complications or the effects of the eating disorder. There are other medical interventions that might be used. And so all those different modes of treatment lead to there being a number of different professionals involved in treatment often. And certainly on a treatment team, you want those other individuals, you want those team members because it's so complex. And then as we'll talk about today, multiple levels of support. And we tend to call this levels of care, but we can think of it as levels of support or intensity of care. And it gets very confusing if somebody's navigating this for the first time or the second time. It can be very confusing. It can be confusing if it's the 10th time, or if you're a professional and it's the 1,000th time. So, so if you feel like it's been hard to navigate, or it's looking like it's difficult to navigate now, um, you would not be alone in that. And we'll hope to provide some information today to help make that a little bit easier. But there are a number of resources that can help us, whether we're professionals or loved ones or individuals needing care. There are multiple ways to try to get some more information to help. Early in my work in the eating disorder field, I had done a presentation during an eating disorder awareness week, and I thought it had gone pretty well. It was a televised kind of morning spot, and tried to give a lot of information about treatment that's available, a lot of hope about the treatment. And I received some feedback from a parent who unfortunately had lost their child to an eating disorder. And she said, on the one hand, she was thankful that I was trying to raise awareness and being part of that. But on the other hand, she was very dismayed that I hadn't paid enough tribute, she thought, to the level of severity and the risk that people have when they have an eating disorder. So I try to be very mindful of that in any sort of time that we're talking about treatment or types of treatment, to be very mindful that eating disorders can be lethal, and they typically rank as either the top or the second highest mortality of any mental health issue. The last few years, substance use disorders have overtaken that, um, but certainly in the field know that professionals, especially people that work in the eating disorder field, recognize that there's a very high risk to these illnesses. And so we want to make sure we have options for people. We want to make sure we're continuing to push the envelope on treatment, availability, access to care, as well as trying to find the care that lines up and is the right fit for people. But these are dangerous illnesses because we have some statistics listed here, but the way I often think about it is that we know that the majority of people with eating disorders are going to also have some form of other mental health issue as well, diagnosed with either some form of depressive disorder or some form of anxiety disorder. We know that the suicide rates are higher for those individuals with those disorders than they are the general population. So we know that someone with an eating disorder will already carry that elevated risk. We have all of these physical effects of the eating disorder that make it possible for someone to die from the eating disorder itself, more from the medical complications. So they have that increased risk. So we have this combination of factors that leave them at higher risk than most other mental health issues, and also higher risk than their peers who don't have any other medical issues. When we start to think about the complexity, it's appropriate to kind of look at all of the different body systems that are affected by eating disorders. And this is not a comprehensive list by any stretch, but I think the number of entries here on this slide and the next can help to show that it is affecting the whole body. And, physicians especially tend to think of the body in these different systems. And really, each system is affected or can be affected by the effects of an eating disorder. So, um, while a lot of our thoughts about eating disorder are in the psychological realm, which is appropriate, it's also important to consider the physical effects that the eating disorder can be having acutely or over the long term. And there's a list here of all of the different body systems involved. Again, not a full comprehensive list, but trying to make the point of how complicated these disorders are. Um, so it's no wonder that it's not a one size fits all in terms of the treatment, that it's not just a one approach that's going to work. So we just saw in the last couple of slides the number of things that can go wrong with the body as an eating disorder is occurring. We also have to be concerned about what can go wrong in the body as treatment is occurring. So it's really an unfortunate set of circumstances that we have to worry about that. And so often in other forms of treatment, whether it's mental health or physical health, if somebody is on the road to treatment, you're breathing a sigh of relief because they're now getting treatment. And for eating disorder treatment, there are complications that can arise with the treatment itself because very often someone comes into treatment where um, they have gotten their body accustomed to whatever eating disorder behaviors that they've had. So if they've been restricting and taking in too few calories or not enough nutrition, their body has usually gotten used to that. And so any disruption in that equilibrium or that homeostasis means that the body is going to take a while to figure out what the new norm is. And so there are these disruptions that can happen. And the most extreme form of disruption is called refeeding syndrome, which is a term that I'm sure is familiar to many of you because it gets talked about in the eating disorder world a lot. Um, but it's a set of disturbances in the body where the body is really having trouble with taking in and utilizing the nutrition that's now available to it. So if we go too fast or too much too fast, we can throw off the body's ability to really adjust. And then we have to be on the lookout for a number of these issues, the most prominent being electrolyte deficiencies that can occur when people are doing what they're supposed to do. They're trying to eat again or try to eat without using eating disorder behaviors, and their body is reacting because that's not the norm it's been used to for a while. And so we have a lot of medical complexity. We have the fact that even when people are receiving treatment, there can be complications that occur. And so, like many illnesses, there's this continuum of levels of intensity or levels of support that someone may need or someone may benefit from. The highest is, of course, if somebody needs immediate medical or psychiatric stabilization, then the next step would be inpatient. There's residential care, which is a little longer than inpatient typically, partial hospitalization, intensive outpatient, and outpatient. We'll try to cover these categories and give a little bit more flavor to what these really represent and what might be reasons that we would consider that. So at the what's considered the lowest level of care or the least intensive level of care is what most of us are familiar with in other types of at least mental health treatment, which is an outpatient treatment. Typically consists of meeting with an outpatient therapist once a week, once every other week, meeting with a dietitian could be once a week. Sometimes it's harder to see a dietitian with that frequency. Could be a primary care provider. There may be a psychiatry provider involved. There may be some outpatient groups that someone goes to, but this is pretty low intensity. It's, seeing someone for about an hour a week or every other week. And this is where most people, I would say, are receiving eating disorder treatment. Higher levels of care are not where the most individuals are receiving treatment. It's in these outpatient levels of care. And then intensive outpatient programs, IOPs, um, typically these are going to be about 3 to 4 hours a day, 3 to 5 days a week, but they will basically ratchet up some of this professional support that's available. And there would still be individual therapy sessions occurring in most of these intensive outpatient programs, but you also introduce more group-based therapy, more other forms of therapy like expressive art or movement therapy. And then you add in therapeutic meals where um, these are essentially groups where professionals have been trained to try to help support individuals with eating disorders through their anxiety, their fears, or their physical challenges that come with trying to complete a meal. So in these programs, typically about one meal at a time or one meal a day would be covered in these groups. The partial hospitalization program is where there's more time each day spent in treatment, typically 6 hours or more per day, and could be 4 or 5 days a week. Some programs will go 6 to 7 days a week. And this is where somebody's acuity is usually higher. They need more support at the mealtime. And by that, I mean, instead of just one meal a day, now in a partial program, they may have two meals, maybe a snack or two that's supported by professionals doing this encouraging type of support. And they are likely then at this level of care to have more access to medical and psychiatric services. Different forms of therapy enter the picture, the higher level of care you go. There's more psychoeducation that is done at this level of care, and more often we'll have some case management services to try to help people because once we get to a point where people are in treatment, pretty much the full day, that means they're missing school, they're missing work, they might be having trouble with other areas of functioning that case management would be helpful. And all of this has to be with a lot of coordination with any of the external or outpatient providers that people would be returning to care to. And then we have the 24/7 levels of care, residential and inpatient. These are both still considered, for the most part, mental health treatment. So mental health residentials or even most of the inpatient units for eating disorders are psychiatry inpatient units, where people do need 24/7 care typically, where they need all of their meals, all of their snacks to be supported by people who have that experience and training on how to help people be successful with the completion and the nutritional rehabilitation. All of the same things that you would have in the partial level of care, and then just ratcheted up in terms of amount of time spent in groups, amount of time spent in different forms of therapy, and then having that 24/7 support in the inpatient level of care, you're really ratcheting up the nursing care because typically people have had a reason to be at that level of care that involves medical complications as well as any psychiatric or nutritional complications. This hopefully is helpful in kind of distilling all of that into a helpful little comparison here about what does all this really mean. And I think I use the term ratcheting up the level of professional support. You can see that in the column under hours, where in outpatient care, you're at 1 hour a week of typically of professional support. When you get to an inpatient setting, you have 168 hours a week that you have professional support around you. So really just a nice guideline of how much professional support is added into the picture. And in these higher levels of care, it's a multidisciplinary approach, as I alluded to earlier. And I know in the outpatient level of care, it often involves one to a few of these individuals. In higher levels of care, it's the norm to have multiple different disciplines working together to try to help someone because that's what we are trying to do is trying to increase the level of professional support. And so I know one of the main questions here is a higher level of care needed? And um, I think I've said already that most individuals are treated in outpatient, um, but most people in outpatient treatment can be treated successfully without needing a higher level of support. Um, there aren't really a lot of good statistics on exactly what that looks like in terms of how many can do it okay in outpatient services, but certainly newer treatment techniques like family-based therapy, FBT, is going to improve the chances of outpatient treatment compared to before that was available. And so as newer things come around to help in outpatient treatment, there may be more people that could be helped at that level of care. And some people might have, especially if they receive treatment very early on in their life, may have just a one-time flare-up or episode of eating disorder, coming to fruition, then receive treatment, and then really enter a very full remission the rest of their life. It's beautiful when it happens. It unfortunately is not the norm. That doesn't mean that these illnesses are not treatable or not able to be helped, but to get a full remission where somebody doesn't even have, a minor level of symptom occurrence is not the norm. And so we're more often looking at it in a situation where somebody's developing a way of managing their illness over time, and they may have great functioning and great success in their life, and really only receiving minimal treatment intervention or treatment support, but they'll still say that the eating disorder thoughts are still very much a part of their life, or they're in the background, but they're not front burner, but they're at least back burner. And so that sort of course then for individuals means they may need at times more support, even though they can go months or years with needing very little professional support. Um, Individuals with these illnesses can have a recurrence of the more severe symptoms and behaviors, even if all the outpatient care is excellent, even if all of the support system is great, even if the individual is doing all that they can to try to prevent it. Um, like other illnesses, I think of the ones that come to mind for me that people kind of manage through their life, or have to manage at some level, something like diabetes, or where people may not need hospitalization or higher levels of care the vast, vast, vast majority of the time, but there could be something that throws their illness off course. Somebody with diabetes, it could be having an infection or developing an illness that then disrupts their blood sugar regulation. They end up in the hospital for a short period of time to try to get things corrected. I think of that similarly with individuals with eating disorders, where they could be going along great, and maybe there's a psychosocial stressor. There could be, going away to college. There could be having loss of a loved one, something that can throw them off course, um, even if they're trying to do everything possible, and even if their support system is great. There are times when the symptoms and behaviors can get worse, and then that may be a time for a short period of time that they may need a higher level of care. Really wanted to make sure that just say out loud that I as a psychiatrist in this field, and I think all of the people that I work with on the professional side, do not think that needing a higher level of care is any sort of implication on how the outpatient care is, or how the support is among the loved ones. It's not a failure of that type of approach or that type of care. Um, it is because these illnesses are complicated and they have a circuitous course over the course of people's lives. And there will be times when individuals need more professional support, times when they need less. And it's, I hope it's a helpful construct to think of it that way, because it really can occur even if everybody's doing all the right things. And please know that doing all those right things means that it occurs much less frequently, and often the the episodes are much less severe if people are able to have all these advantages of having good motivation and having a good support system and having a good outpatient care. And I'm sure all of us, when we think about what we would like recovery to look like, we would like it to be this linear line, this dashed line of things just getting better gradually over time. And at least in my experience, it's much more common for it to be this, this roller coaster kind of ride that is trending towards improvement and trending towards better functioning and trending towards it being on the back burner. But there may be these ups and downs, and sometimes when the level of progress is dipping, where somebody's having the increased symptoms and behaviors, that's where more professional support, more of these higher levels of care could be very important. I think I mentioned earlier that there are some guidelines around levels of care. When we talk about these different levels of intensity, there are guides about how to match up symptoms and behaviors with the level of professional support that would be recommended. These get very complicated also. And so even for those of us working in this every day, we have these guidelines, but we also are trying to piece together the individual needs of a person, their psychosocial situations, their levels of support that they have available to them. So there is no formula for this. There's no clear black and white, but these guides are helpful. And so these links should be available to you when we send out when we send these out, or you can access these guidelines, but they do get kind of complicated with all of the different things because we have to look at physical health issues, we have to look at mental health issues, we have to look at support system availability and bandwidth, we have to look at a person's level of readiness, and so many different things, and it gets complicated. But more often, it when people are seeking care, or loved ones are seeking, or people are seeking care for their loved ones, um, it's a little simpler. They just know that it's whatever's happening now is not working well enough, and we need something more. And we're not sure what that is, but we want to seek something that'll provide more support. And so that's where you start to seek the help that from professionals that could, if you don't have it available already, there are resources available to seek professional assessment and support around what would be the best kind of recommendation for this level of symptoms and behaviors. So the Red Sea Consortium is a group of eating disorder treatment centers that work together to try to create levels of care criteria. They also create some guides for how to choose the right levels of care. But this list is long here in terms of the considerations. So there are many different factors that come to play here, but I think for individuals and families or loved ones thinking of this, it's really about whatever's going on right now isn't working, or it's not working well enough, and we need something more. Despite having these really complicated level of care guidelines available to us, I'll share just some more of the kind of the red flags. These are not black and white criteria or formula, but these are kind of the red flags from the medical, psychiatric, and kind of behavioral realm that have been helpful for me in trying to determine, when somebody would likely need or be very beneficial if they were at a higher level of care. Because some of it has to do with just some of these aren't available in outpatient very easily. So if someone needs IV fluids, that's going to not only mean that a higher level of care would perhaps have that availability, but it also means that they probably have enough medical complication going on because they need IV fluids is just a sign that there's a lot more problem going on physically. If somebody needs help with getting nutrition some way other than eating and drinking, so enteral feeding means you're feeding the body through some other means. It could be through a tube that goes into the stomach or into the small intestines. It could be through a central IV. But if you're at that level, you would likely need a higher level of care. Um, there are very few occasions where that can be managed, at least in the kind of the acute phases in an outpatient setting or at home. And if there are significant lab abnormalities, that's a red flag of some minor abnormalities might be able to be managed outside of a higher level of care, but if they're getting substantial, it means that things are changing rapidly enough that more medical monitoring is necessary. Similar to there's a severely slowed heart rate or abnormal rhythms in the heart, the further sign that the body has been you know damaged by the eating disorder, and there's more medical monitoring that's needed. Blood pressure abnormalities, and then even if someone's eating disorder symptoms and behaviors may not by themselves warrant a higher level of care, if they also have one of these co-occurring medical complications, their treatment course is going to be much more complicated than other people. So, for example, people with diabetes, even if their eating disorder symptoms and behaviors may be more moderate, they may need a higher level of care. Very often, they do need a higher level of care because trying to manage somebody's diabetes while they're going through any process of changing their nutritional intake is very, very complicated. And it's hard to do even in treatment settings. So it's not something that would typically be recommended in a home setting. Cardiac disease, kidney failure, liver disease, all things that would make this process very difficult to do outside of a higher level of care. Um, if somebody has blood in their vomit or cough, that's a sign that they should at least get that assessed urgently. If somebody's having seizures and it's intertwined with their eating disorder, another reason to look at a higher level of care. Um, People who are having shortness of breath with minimal activity or having excessive swelling or edema, these are things that don't happen to people typically unless they're having significant complications with their heart or their kidneys. And for those reasons, a higher level of care would typically be warranted. And those are kind of the red flags that at least professionals are looking for when they're trying to make these decisions. Similarly, psychiatric assessment leads to some red flags about what would require a higher level of care or seem like it would require a higher level of care. Certainly, if there's a safety issue like suicidal ideation or recent suicide attempt, and significant self-injurious behavior, those are things that really require emergent interventions and assessment. Um, Less so on the, like not necessarily an emergency room visit, but when I hear that someone is having panic attacks at every meal or snack, even if everything else is pointing towards a lower level of care, that's a red flag for me that they may need a higher level of care because it's very difficult to get any traction going if somebody's having that level of anxiety at every meal and every snack. If we're seeing cognitive slowing, um, in an individual who otherwise has normal cognitive functioning, that's also a sign that the eating disorder is at a level of severity that we would want to be able to monitor more closely. And so significant co-occurrence of mental illness, similar to the medical illnesses, these can make the course much more complicated, especially if these co-occurring illnesses are not stable. So it's the red flag. It's not a prescription that it has to be a higher level of care, but it is a red flag that's where I would probably lean. And then, if we have people who need frequent medication adjustments, that's much easier to do in a higher level of care. There are psychiatry providers, medical providers that are there seeing folks, once, twice a week, all the way up to every day. And if somebody needs involuntary treatment more often for their co-occurring mental health issues, sometimes for their eating disorder issues, that also is something that would be a higher level of care. And then there wasn't a great category name for this, so just behavioral red flags is the way I think of whether it's how things are progressing in treatment or how somebody is doing with their readiness for care. Um, but the overarching thing is that if there's a lack of progress occurring in the current treatment efforts, especially if somebody may be trying very hard, and their loved ones, their outpatient team may be trying very hard, but it's still making it very difficult for them to get weight restoration going, to create any sort of change in what they're doing with behaviors. Like if they're purging multiple times a day and it's not changing without patient care, it's time to start thinking about a different approach. Um, and similar, if the eating disorder behavior frequency is really high, um, you know, there are always exceptions to the rule, but most of the time, in my experience, if somebody is engaged in behaviors, I'll just use the purging example again, if they're doing that multiple times per day, it's been very uncommon in my experience that they're going to be able to get enough progress with that unless they have some higher level of support with trying to change that behavior. Again, there are exceptions to that, but it's so difficult to make these changes if the behaviors are happening that often. Um, Somebody's not cooperating with outpatient care, that's another reason to consider a different type of care. Um, if the individual is trying, but they feel like these behaviors are out of control or they take on a compulsive quality, they may do better in a setting that's pretty much designed to try to reduce the likelihood that people will be able to engage in these behaviors. Um, and if somebody has, everyone has a different amount of support available at home. So if somebody has very minimal support in their life outside of a treatment setting, then, it may be more of a sign that they would do better getting started in a treatment center and then trying to put together a good plan for what type of support they would need at home. There are challenges with this, even when everybody agrees that higher level of care is a good idea. There are still challenges to this, and which is probably the reason why there's hesitation sometimes to go ahead and do that next step. But can be disruptive. 24-hour care means you're in a different setting, 24/7, sometimes for weeks at a time. Even doing something a little less intense like partial hospital programs is basically a full day of therapy work and therapeutic meal support. And then IOP is still, 3 to 4 hours, several days a week. So these are things that create challenges for individuals, even if they recognize that there could be some benefit to it. Um, there are typically costs involved. It's very seldom that somebody wouldn't have any out-of-pocket costs for treatment, just like any other treatment, but sometimes our mental health, eating disorders, substance use treatment sometimes has more costs associated with it than maybe some of our medical illnesses. So there's a lot of work and lobbying that still needs to be done to ensure that we have better parity on that. Um, but very few people can pay for the entire treatment themselves, so most are relying on insurance, and insurance can be unpredictable at times in terms of what what will be authorized and what won't. So that is certainly a factor. And care sometimes requires travel because you may not have a treatment center right around the corner from where you live. Um, and then it's not only the individual who's getting treatment, but their support system typically is involved in the treatment as well, which is a good thing, but it is important to know that will affect the family unit or the support system. And understandably, that may provide more hesitation about trying to seek the higher level of care. So it's a disruption and no question about it. Um, and when we're on the treatment side trying to help people make these decisions, we're also trying to help them factor in what disruption is the eating disorder causing in their life. And are they really able to function the way they want to function? Are they really able to do all the things that they want to do in current state? And certainly then, if there are more acute issues or more serious safety concerns, then that balance goes over towards the need for the higher level of care. But um, but these it seeking treatment does have its drawbacks, of course. So it's a difficult decision sometimes for people. Um, just leave this. I'll just let you have this slide for reference for later viewing. But there's a lot of common questions that families and individuals have when they're looking at treatment, all the way from where to start to how does it impact school. So all of these are very appropriate questions and very important, that whether it's your treatment providers or a treatment center that you're thinking of going to, that they can help you um, learn how they're going to approach these areas. But these are things you want to kind of consider when you're thinking about a higher level of care and trying to decide among places. And as I said, it's a difficult path to navigate. So there are many different ways to enter treatment. That's one good thing. Most treatment or most places that provide treatment offer, self-referral where people can call in or fill out forms on a website and get set up for a full screening. Or it could start with outpatient providers. And so when you start look for higher levels of care, oftentimes the outpatient providers will have good recommendations for what places they've worked with and where they think that the best care is going to exist for your loved one or for an individual if it's you looking for the treatment. And if you don't get a lot of options provided that way, like I said, you can check the website of eating disorder programs near you. If you're unfamiliar with how to do that, there's a link here for Find ED Help, run by the National Alliance for Eating Disorder, to try to help people navigate the world of treatment that's available. Um, Again, you can call specific places if you have a referral, not meaning a formal referral where your provider has had to call in and do some sort of uh, pre-approval process, but more talking about if your outpatient provider has suggested a place or you find a place online, you can certainly do the whole process with the site, with the treatment center directly. But if you're unfamiliar with the different treatment centers or want help with this, that's where the National Alliance for Eating Disorder helpline could come in handy. Um, but it's important to know that you don't have to have a referral. It's not a kind of a gatekeeper type approach where a primary care provider has to refer you. You may have a specific insurance that requires that, but the field itself doesn't require it. And most treatment centers would not require that sort of approach. And then just thought I would try to pull in some of the points that I hope would be helpful take-home points here. Um, First, that many people are successfully treated in outpatient treatment, and especially when there can be more disciplines involved where it's not just a single provider, it can be very effective. And these are oftentimes illnesses that people are dealing with at some degree or another for the long term. And there will be times perhaps where if there's increased severity, even if there's really good outpatient care going on, even if there's good support at home, people would benefit from or need or require a higher level of care. Um, this is not an implication then of anything going on with the support or the outpatient treatment. It is just a matter of the illness itself having periods of time where there may be more symptoms and behaviors occurring. It is relatively short term, even when you're talking about a residential stay or a stay in a partial program that can be several weeks. That is still a short term when it's compared to the rest of the person's life or the longer term outpatient approaches that will be taken. And also, a point that I didn't make until now necessarily is that all of the questions about when to seek a higher level of care that families and support systems have or individuals have are very much the same questions that treatment providers have. We all struggle with this a lot too. We feel a sense of guilt or like we've let somebody down if we're trying to treat them in a lower level of care like an IOP, and we have to recommend that they go to a residential or inpatient, we all feel a sense of like, what did we do wrong? What could we have done differently? How could we have helped this person more so that they could have, stayed in this level of care? So it's a common question that people are that ask, and we have these professional guidelines around what constitutes, symptoms that are appropriate for different levels of care, and yet it's very complicated. There are individual circumstances that we all take into consideration. But please know that professional teams undergo a lot of stress with these decisions as well. Um, and, I personally try to think of the higher level of care like in many other medical and mental health issues, that it's simply additional services when symptoms are severe enough to warrant it. Um, and just things that, like many illnesses will require somebody to be in the hospital for short periods of time. People with eating disorders may have a need for a slightly higher level of care at different times. Um, and another thing to remember is that even though I mentioned that most of the people in treatment are in outpatient treatment, it is common for people to have that turning point or have that epiphany that we're all looking for when we're trying to improve or recover from something, that they have that in the higher levels of care, partially because, folks are concentrating so much on the treatment and they have so much therapy occurring to try to make those connections, partly because they're removed from some of the other stresses of their life, like school or work or something. Not that that's good to be removed from those things long term, but if they're contributing factors and somebody has a chance to um, really have a concentrated time of treatment, it can be the place where they have some of those turning points. And it's really gratifying when we see that in higher levels of care. All of that's with the appreciation of knowing that there are a lot of other, discoveries and epiphanies and great steps in therapy that are going to happen outside of a higher level of care. So with that, those are my, I guess, prepared remarks. I will stop sharing, and I think Jenny will be able to help us go through some questions.
Yes, thank you so much for all that helpful information, Brad. I really appreciate it. It is a very complicated topic, and we have some great questions. The first one is needing higher levels of care associated with poorer outcomes or prognosis? In other words, do patients in higher levels of care for long periods seem to fare worse over time?
Um, well, I'll first acknowledge that I'd have to do a little digging in the research to find if there's even a study that addresses that real directly. Um, but I'll try to answer it based on, what I know of the literature and just anecdotal experience of a lot of years in this. Um, you know, the more times that somebody needs a higher level of care, almost by definition, they have a more complicated or more severe form of the illness. And so we would anticipate that their prognosis may be a little not as good as someone else who has only needed a higher level of care once or twice, similar to how I'm using the diabetes analogy, that if somebody with diabetes needs to be in the hospital once a year because of disruption in their diabetes care, they're by definition have a more complicated course of diabetes than someone who hasn't needed to go back in the hospital for that. So you would expect that they would have, not as good of a prognosis as somebody who's had very good stability with their diabetes long term.
Mm, that makes a lot of sense. And from what I could tell from your presentation, there are just a lot of gray areas. And it was really interesting to hear you say that the treatment providers also struggle with the same questions. So maybe collaborating as much as you can and making the best decision you can with the most information that you have as possible and making changes where needed. That was just my comment, but we have more questions. The next one is, what is your experience in using contracts with loved ones to agree that if progress isn't made, that they will need to accept a higher level of care?
I've had experiences of that. You know, it can be helpful. It really, as with all these things, it can depend on the individual, the relationship of who's entering that contract with them. Um, treatment providers sometimes do those contracts. Families do those kind of contracts, like we'll try this for a while. Um, or sometimes it's called a treatment agreement if it's professionals doing it. They can be effective because um, you know, but they're not foolproof. People can, just like any other contract, people can not honor the contract, so to speak, and decide they're not going to go at the last minute. Um, but there is something I think about making an agreement with someone and then following through, especially if the relationship is strong and especially if it's done in a way that's loving and supportive and feels that way to the individual. I think I've seen it be successful probably more commonly than it hurting or not working.
Yeah, that makes a lot of sense. The next question, how do you approach this with someone who's of age? And I'm assuming that means as an adult, 18 and over. We were successful in getting them inpatient once through persistent familial begging. That was the only word that came to mind to describe it. But they discharged themselves and refused to acknowledge anything related to the eating disorder. Myself and the other caregiver have kind of turned our house into an inpatient facility. They're not cooperative, and we struggle to find leverage. Um, anyway, they don't feel like they're making any progress. So how do you approach that situation?
First, for whoever wrote it, I'm sure there are others that have been in similar situations out there. Just really, feel for the situation. It's quite a bind, and hats off to every family member, every loved one who's been trying to support someone in anything close to this type of level of severity. Um, Really, it's complicated. I think it's going to be perhaps about finding where that leverage is, and that's different for every person. It's different for every family. Um, and the stakes are high. I know that, it's tough to apply like contracts or agreements if you are worried that, that if you remove some level of support, whether that's like removing financial support or removing housing or removing something as, or whatever you're going to do to try to hold up some sort of contract or agreement, it's there are risks with that, especially with illnesses that are this bad. Um, so I think it has to be something you're comfortable with about, what can we, feel comfortable and good about in terms of what we're doing. Um, you know, but it, probably requires some form of leverage to help move the needle. And I say that with the understanding that I'm sure every reasonable way of appealing to someone, in the most loving and compassionate ways have been utilized. And then still at this moment, that's where you start to look at how can a family or how could treatment providers start getting some leverage for you know going in, and that's where I've seen it done through financial leverage or through some sort of, something being removed from what's being provided to enable, what's going on right now.
Thank you so much for sharing your time and your knowledge with us today. I think we are out of time. This is such an important topic for parents and caregivers, and you gave us so much helpful information to help us decide when a higher level of care is needed, even though it's a really difficult thing to figure out. And thank you again to the Emily Program for sponsoring today's webinar. And before we wrap up, I just was going to say that Feast relies on the generosity of our community to keep these kinds of programs going. So if you enjoyed this webinar and you're able to, we would really appreciate a donation. And we also hope that you will be able to join us for our next webinar, which will be on facing mealtime challenges. And it's on November 12th at the same time, noon Eastern, 5 p.m. UK time. And thank you so much again, Brad, and thank you all for being here.
Thank you.